Well, welcome everyone. This is Ruth Hanston, and I'd like to welcome you to Leadership at the Point of Care. This is part 3, and it was about effective assignments for RNs and assistive personnel. So certainly it's a lot of effort to be placed in making those assignments work for our patients and their families. So let's just start with talking a little bit about myself. If you haven't joined us for our other webinars, you may not know about me. So I'm Ruth Hanston, and I've worked with about 175 organizations nationally now related to delegation and supervision and a shared mental model for how we work together effectively in teams, which makes a big difference in clinical outcomes and your own satisfaction with the work you do. So this particular discussion has to do with some of the information in the delegation book or the relationship and results-oriented healthcare book. My doctoral research was on critical thinking and clinical judgment. So we'll be talking today a little bit about some critical thinking concepts or clinical reasoning concepts related to how complex the process is that it takes to make excellent assignments. If you have not already downloaded from the Hanston Learning Center the handouts, we have handouts that start out with leadership at the point of care with a great quote from Florence Nightingale about delegation and supervision. And on the second page at the top will be your learning objectives. So the learning objectives are there as well as your critical thinking questions. The 3 major objectives that we'll be discussing, we will be allowing you to review the concepts of primary nursing, functional nursing, and team configuration. We will be looking at the criteria that are used for making assignments matching the right person with the right task. And we'll be looking at how you could actually take the information we discussed to apply it to, some exercises that we have, but also to allow you to figure out how you might take this back to your workplace to help you deploy available staff with the right amount of direction and ongoing observation and supervision, evaluation, and feedback that is required by our State Practice Act. So those are our objectives, and that brings us then to reflection. One of the things I learned in my doctoral research was that I tried to figure out how do we think better about how we do our work. And the critical thinking questions will allow you to really step back and be that internal consultant to your own workplace and think about, how did you even learn to make assignments? How do nurses learn? And oftentimes it's just on-the-job training, and people learn as they go, and it's something that they do through trial and error. So we're going to be a little bit more planful about that to really think out how people make those decisions and that using what criteria in the way that they decide who should be doing what in the care that needs to be done. Secondarily, how do you measure the effectiveness of assignments? Many times it's, whether or not somebody's complaining after, in the middle of the day or at the beginning or at the end of the day and saying, oh, this is a terrible assignment. Is it through complaints or grinching of our fellow workers? Is it through end results, through knowing that the care has been done, making sure there are no omissions? Is it through job satisfaction or patient results? How do we measure the effectiveness of those assignments? Thirdly, in what manner does your current assignment method show how nursing assistants and other technicians are reporting information, and also to whom are they accountable for the work that they're doing and making sure that the care is not omitted? And assignment methods, that seems to be one of the major issues that we see nationally. So assignments showing that clear relationship of who's taking care of patients and who's reporting to whom with the care that's being done with those patients. And fourthly, how can an assignment affect the end results that patients and families experience? In our earlier sections of this delegation supervision module, we've talked about the impact of missed care tasks. What if the patients aren't turned, if they aren't ambulated, the pressure ulcers, the DVTs, the things that occur if we're not doing our work and our care appropriately. Fifthly, think about when you have experienced excellent teamwork, excellent assignments, and what were the qualities that occurred when those did. You had a great assignment. Was it only related to numbers? Was it the types of patients? Was it the way that you communicated together as personnel in teams? If you have not ever had a good assignment or you've not experienced that kind of teamwork, why don't you think about asking someone who may have experienced that and really taking their information to heart about what ideas might work better than the current methods that you're using for making assignments in your particular unit. And, in this work that we're doing in Section 3 here, we're really talking about, acute care assignments. So this is about what happens on a med-surg unit, for example, in acute care. So let's also then take a look at the 5 rights of delegation and supervision. And when we think about, again, the National Council of State Boards of Nursing and this memory device that we have to help us remember how we're using the personnel effectively that we have available to us. So under the right circumstances, and you'll see this on page 3 of your handouts, based on that setting, the patient acuity, how much supervision is needed. If you have a whole bunch of novices or new grads, you need to supervise them more. So under those right circumstances, you have to actually do the complex critical thinking skill and process of matching a competent person with a task that they can do competently that's within their job description and scope of practice. Then also setting up the assignment so that they have a chance to get the right direction and communication from the get-go, and also the right supervision and feedback throughout the shift as well as to the end of the shift. So that is what we do to be effective delegators, supervisors, and for the best teamwork at the point of care. So go to page 4 now of your handouts, and we'll talk about how we create care delivery structures. And we're going to look at some principles or recommendations before we actually do an assignment worksheet or look at how we might make assignments differently. We also want to take a look at the evidence and some of the research related to how we make assignments and even shift length. If we think about care delivery structures and how we've set up the work that needs to be done, if we go back to Florence Nightingale, they had a whole bunch of people in one room in a ward, and then you could visualize all those patients. There wasn't a lot of privacy, but it allowed just a couple of nurses with some assistant personnel to take care of a large group of patients. And we move from that to what we're really looking at now for the complexity of patient care and the acuity of the patients that we're caring for in a hospital setting. We want to really look at some of the evidence around what works well in teamwork and working together effectively. What could a perfect care model look like? How would you measure that? How would you know if we were effective at the work being done? And what criteria or factors are considered? And how you'll evaluate, again, what results will you expect if we're doing the care appropriately? Should not we expect that patient results are good, nurse-sensitive indicators such as, no falls with injury, no pressure ulcers, no urinary tract infections from catheters, all of those things, surgical site infections. How are we going to evaluate that model? Do we have the right numbers and types of people for the types of patients we have? Care models from the past. Well, let's just take a trip down memory lane and talk about some of the ways that we've taken care of patients in the past, because we can learn from those ideas that will help us broaden our mindset around how we can do work. Functional nursing is still done in a lot of skilled nursing facilities where there's a medication RN or maybe LPN and a treatment RN or someone who's really delegating to nursing assistants and the LPN. in the past, of course, we did functional nursing, probably 60s and 70s of the last century, of the 1900s, and it worked well, especially when you did not have enough nurses to do a lot of the care. However, remembering that if you're really thinking about nurses as being the folks that help navigate the patient through this episode of care, that there might not have been the very best care planning. It could have been very fragmented. Total patient care by an RN was done in the 70s and in some cases in the 80s, where there were not assistive personnel and all the care was done by a registered nurse. Primary care started, and it was Marie Manthey talked about making sure that nurses really rose to the top of their professional role and helped coordinate and plan the care, did the nursing process for that patient throughout that whole hospitalization. And that primary nurse would direct the care, but would be off, of course, on certain days or shifts, and then associate nurses would take over. So that was an idea that was used quite a bit and is still used in different versions. Case management is, of course, when the case is being managed by an RN and sometimes throughout all the episodes of care and out into the community. There are many types of team nursing, different kinds of teams. You might have an RN, LPN, and a nursing assistant working together, or other kind of technicians working with an RN or an LPN with a group of patients. So that depends certainly on the type of care that you are delivering. If you have, an orthopedic unit, post-op ortho, you might have a physical therapy aide as well, or a PT that might be working with you in that team, and other functions. We have other ideas such as geographic assignments or pods, and have nurses working together with assistive personnel in those geographic pods or areas. We also, one of the ideas that has come up recently is a variable and reliable rounder, unlicensed assistive person for rounding every hour on a patient care unit. So that one person is going around every hour and just continually going around the floor, whereas there might be a nursing assistant who is, working with a set of patients with an RN and maybe doing other tasks, but might at some point also do some rounding. So that's, there are different ideas that can be used to help take care of your patients in your particular area. What are the criteria that you use? If you think about the criteria that you use when you're making assignments, we, step back and consider all the various ideas that you have to take into consideration. Besides the 5 rights of delegation and supervision, you're really looking at the patient's needs, and that's probably, the right circumstances, but the patient's needs and how, stable are they, what do we need to do for patient safety, and how sick are they. We may also have state-mandated patient-nurse ratios or breaks being mandated, so that we have to make sure that's a part of our assignment making. That caregiver competency is, the right person to the right task. That we plan for the unexpected and the expected churn or admissions and discharges that may occur in your shift. And certainly, we know if your unit usually stays full and it's a Tuesday and you always have surgeries on Tuesday, and you know what the surgery schedule looks like, you plan for the first, second, and third admission and the discharges that are planned. Continuity of care is certainly a part of what we look at and think about as we prioritize how to make assignments. Continuity of care being, who are the RNs that have been taking care of these patients, and do they want to keep that same group, because the second day is certainly easier than the first day when you know your patients better. Infection control. How many isolations can one person handle? Do you have a lot of MRSA that you're dealing with, or other kinds of infections and isolation? Those have to be taken into consideration. Geography is a big deal. So how you're unit is set up. Is it a racetrack configuration? Is it a long unit? And if we have people, walking all over the place, are they able to actually visualize and talk to each other and see their patients? That's an important thing to think about, especially when we talk about the aging population of nurses, which is clearly a factor, or other needs that might occur with the folks that you've got available to work with you. And there might be specific things that staff have requests around. If they've had a recent death in their family from cancer, maybe they're not, really excited about taking care of patients who are at that point right now, and they may need to ask for, a different kind of assignment. So just thinking about that, that goes, all these ideas and factors that you take into consideration go way beyond the nurse-patient ratio idea that nurses often hold so firmly to, where, I only take 5 patients or I only take 6 patients, that's all I'll do. And really having to broaden our mindset from that, because certainly, the patient itself, the acuity makes a huge difference. I want to make just a quick note about how we assign RNs and unlicensed assistive personnel. I wanted to point out there's a video in the Hanston Learning Center that we placed for you, so you can listen to my commentary on this. And I really think it's important for us to look at setting up assignments so that nursing assistants are clear about who they're reporting to, and that there's a connection with the RNs and the nursing assistants. And so that's something that I'll leave you to listen to that, and we'll talk about that more as we go through this webinar. But very important point that I think is being missed in some organizations. As we plan our care delivery structure, remembering that we have these 5 rights that are behind our decision-making, and those 5 rights, really there are some non-negotiables based on your Nurse Practice Act, that the assignments have to reflect who's accountable to watch over and supervise the nursing assistants that you're working with. So go back to your State Practice Act and look at your organizational job descriptions, and also look at your specialty organization's recommendations. So the ANA, the AORN, the Emergency Nurses Association, the AACN, all of these organizations are really making comments about how do we use technicians, what are our recommendations about nurse-to-patient ratios even, in critical care, how many patients and what kinds of acuity would we recommend for standards. Those are other ideas that you want to use as you begin to look at the care delivery organization and the model that you use. So ideas for you. So what methods really work with assigning RNs and unlicensed assistive personnel? So those are your nursing assistants, patient care techs. Let's take some time to think this through. I want to first talk about what methods are really usually work better, and then we'll look into a little more detail on some of the research. Research tells us that the closer relationships that you can have with each other will help the teamwork. That if an unlicensed person or a nursing assistant is paired with an RN, or there are fewer than 2 RNs to 1 nursing assistant, as you see on the left there with the group of patients, that actually works better for the teamwork and for the supervision piece. That then these nurses can set up planning and checkpoints and collaboration and feedback with the person who's working with them, with their team members, and it does allow for more coordination of care. We also know that if people work together more frequently, they're able to get their teamwork in sync, they work together better, and we want to be able to give each other feedback. So the more comfort that you have with giving feedback, those skills, as well as having that ongoing relationship, that helps with working together effectively. And so certainly thinking about the staff needs and requests as well. So if you look at non-traditional models of care delivery, we thought it would be interesting to just look at some of the work on this. And Tiedemann and Lukenland have done some research on this about, how do we, what kind of care delivery models seem to work. And they could say, hey, there's not a whole lot of strong evidence, and this is from 2004 and 2005, but still, there's not a lot of evidence about one perfect way of care delivery. So we have to develop it based on the kinds of patients and the personnel that you have available in your own area. Communication and numbers of people to communicate with is an important factor as well. So if 3 people are working together, there are 3 one-to-one interactions when you're trying to share information. If another person is added, there are 6. If there are 12 team members, you can have 66 one-to-one interactions. And this study in 2005 showed that nurses on a med-surg area would work with an average of 36 different people in a month. And that is very difficult. So if we cluster teams together, it allowed them to have a better ability to function. They were happier with their work, and there was better quality in teamwork. But if that's the case and you want to cluster your teams together, then people have to agree to some flexibility about one or more patient load changes. So if you look at our graphic here, you can see the numbers of interactions that occur when there are multiple people working together. And so it really does make it difficult if you're having to communicate with a lot of people on a daily basis and you don't know quite who you're going to be working with over and over and over. You'll notice that Kalish is in a lot of this research, and B. Kalish has done a lot of research related to how to make work better on teams. And what she says as far as working the same shifts, we know that working the same shift decreases the number of staff that everybody has to work with, and it allows you to actually put together some stable teams, and that allowed for higher quality at lower cost. This is a 2008 study, but I think people aren't doing a lot of having to go to different shifts back and forth and all of that now, but it's just good to keep that in mind. Shift length is another issue that's come up again and again and again, and I think we need to be aware of the challenges with 12-hour shifts being long and more errors with the 12-hour shifts. Toward the end of those shifts, it's hard to, keep your mind working effectively. So if there's less overtime, there seems to be a correlation with better teamwork. And so the 8 and 10-hour shift workers perceived that there was better teamwork, but the combination of 8 and 12 was difficult for folks because, and I know you've had to do that, I think, for some folks with older workers needing the 8 hours and the younger workers wanting the 12 hours because of their family situation and such. But that combination, that 4 hours, that if you have that 4 hours gap and who fills that gap and the multiple shift reports that have to be done really creates a lot of problem for functioning with team. So what happens with a tired team versus that's effective versus a familiar team and the kinds of errors? So we found that familiarity and effectiveness, even if they're tired, was better than a new rested team. So, again, that familiarity and effectiveness, very important. If we look at the overview of teamwork research and what really works to improve the teamwork, we know that there has to be good team leadership, and someone will emerge if there's not a good team leader. Normally somebody kind of takes over that because people will look to somebody to help coordinate and lead. There has to be a collective orientation, meaning that we're not all individuals working separately or working against each other in competition, but that we're all working together to help the patient. There also must be, in the most effective teams, mutual performance monitoring, meaning that I notice if you need help, We can also notice if someone's not doing well and they are given feedback, or if they're doing very well, that there's some mutual performance monitoring going both ways, and that we back each other up, that we can adapt to situations that occur. That also then, a really important point, that we have a shared mental model. And I will talk more about shared mental models as we go through our work today in this webinar, but I wanted to really point out the idea of shared mental models means that we have a map in our brains, or an architecture or scaffolding in our brains of how we're going to work together. We're all on the same page. We know how we're going to communicate. We know how we're going to progress through the shift, how we get our information, how we report new information, how we get, talk to each other before and after breaks and meals, how we offer feedback, both negative and positive, how we debrief the work together and improve our teamwork. That's a shared mental model or plan for what happens from the beginning of the shift till the end of the shift and how we connect. There has to be that closed loop communication, which means that if you report something to me, let's say the nursing assistant reports to me about a blood pressure problem, I get back to her on it and I follow through with the physician, for example, that if the things aren't just out there, not getting a response, that there's closed-loop communication. And that helps us develop this mutual trust. We can trust each other to perform. We can trust each other to report and have each other's back. So bringing that all to making assignments. All of our assignments have to be based on the outcomes that are planned for those patients. We've talked in the earlier sections about the 4 Ps, the purpose, picture, plan, and part. And that is one of those shared mental models related to relationship and results-oriented healthcare. We base everything on the purpose and the picture. So why is the patient here? What does he look like now? What does he want to look like? So what are his goals? That's the purpose and the picture. The plan, how are we going to progress through the care, the plan of care, and the part that everyone plays. So the role of the caregivers, but also the role of the patient and family. We make assignments based on who we've got available. And we set up a plan for direction and feedback so that there's initial direction and then there's ongoing communication and feedback throughout the shift. The tasks are planned, and I wanted to bring up the whole idea of nursing assistant to nursing assistant shift report. This video is available for you to listen to on the Hanston Learning Center. And this video talks about some serious problems that have occurred based on having nursing assistants giving report to each other, but really working independently in parallel practice so that the RNs don't know how well the patients ambulate or swallow or how well they're doing with their fluid intake because they're disconnected from the kinds of information that the nursing assistants share with each other on their shift report. And in this particular video, I talk about a scenario that I saw occurring based on having nursing assistant to nursing assistant shift report. So that's a caution for you when you think about how you make assignments. So let's look at the principles or recommendations that are on the bottom of page 4 under Creating Care Delivery Structure on your handout. First of all assignments have to reflect the patient and family current clinical status and desired short and long-term outcomes, or the 4 Ps for that patient. That is no surprise to anyone, but it is a principle of making assignments. Secondarily, all the assignments are based on those 5 rights of delegation and supervision, and we've already talked about this, but certainly that each person is competent to do the task they're assigned. It fits with the job description. The RN leadership communication is initial, ongoing, and includes methods to evaluate whether work is being done and data is being collected, the supervision processes, and really outline when are we going to talk to each other? How are we going to debrief and offer that reciprocal feedback? Thirdly, assignments show that clear lines of authority and responsibility in reporting relationships. If, for example, you're on a patient care unit and right now you only have one nursing assistant, and you as a charge nurse are deploying that nursing assistant, then you really are the person giving them the initial direction. When they're doing actual care with a group of patients that RN is caring for, it's important that there's an ongoing communication with you and that RN so that there's, you're getting information about whether or not that care is being done and that nursing assistant is reporting to the RN as well on any data that's collected. So being real clear on that, that's an important point that is often missed. Fourthly, when the unlicensed person reports to more than 2 RNs, we just ask that you consider streamlining that and making sure that you group the care so that the nursing assistants are not reporting to 3 or more RNs, and it's such a dissatisfier for them, and we find that care is missed, that nursing assistants that are conscientious are overwhelmed and feel that they are never going to get the work done that is required. So it's a difficult thing for patients and for staff. Fifthly, realize that, we may need to, on your unit, you may go back to your unit council and you may say, hey, we've got to think about how we change the charge nurse role or the kinds of unlicensed assistive personnel that we use, or gee, maybe we need to hire an LPN, or maybe we need different kinds of support staff or technicians or therapists. We may need to alter shift times. Maybe we have the nursing assistants coming in at 0600 and we come in at 0630. Really opening your mental handcuffs, if you will, and taking those off and saying, well, we might have to consider how we do our care differently so that we can get the best practices to occur. That being said, let's take a minute to look at different kinds of charge RN roles, because if you've worked in one facility your whole career, you may not be aware of the different charge RN roles that are exemplified in different organizations. Now, I think of them in 3 different ways, and they're often a combination of these, but first one is a traffic cop, and the second is a wisdom worker, and the third is what I called harried Harriet. That's doing it all. So the traffic cop is the person that just is forced to do this job, but they got to have somebody to decide where they're going to put patients. So what bed gets to be filled with the new admit or the direct admit, and she or he may have this full patient assignment, and sometimes they're kind of martyrs, and they'll take on the hardest assignment on the floor because, that's what they do best. And so, it may be really unclear because other people might float onto the floor and say, hey, on my floor, I expect the charge nurse to do my admissions until I can get there, or discharge my patients and call physicians for me, and they're not able to do it because they've got that full patient assignment. Okay, so traffic cop is one iteration of what a charge nurse role can look like. The other one is the wisdom worker, and this person knows this specialty, oh my, yes, seasoned, knows it inside and out. They review the case progress, they're rounding, they're coaching, they're teaching, they're mentoring, leading, and they may not have a full patient assignment, or maybe they don't have any patient assignment, and they will help with admissions, discharges. They're making sure patients are happy, and they're dealing with any issues that might come up. If there's an unhappy family member or physician, they're dealing with it. So really a wise, seasoned individual who's keeping the floor going well. And then we have harried Harriet, and I put a little lipstick on her because she needs her lipstick, because everyone is expecting her to plan care and schedule and staff and get the bed assignments and problem solve and deal with the physicians and deal with the families and every question that needs to be asked. So harried Harriet doesn't work as a model, but we just want you to consider, are any of the roles that your charge nurses are taking, are they erring on one of these sides? And is it a reasonable role? And what do you need? If you have all new grads on your night shift, you need a wisdom worker, and you need that person not to take patients if you're going to expect them to be teaching and leading and helping mentor those new grads and checking them off and all of that. So think about, how you want that charge RN role to look. So I just, think about that, and then that brings us back to our original discussion of what methods work the best for assignments. So overview, close relationships, pairing or fewer RNs with an unlicensed person so that they're not reporting to bazillion RNs, that we set up a plan for how we work together and do checkpoints. We have ongoing relationships, fewer changes so teams can get used to each other if that is anywhere possible in your particular method of doing scheduling, that you can get a point to give each other feedback so that you can develop that team, and that we also think about those folks that are working with us. Do you have people who are aging that need to walk a little less, or what is it that works with the group that we have with us on our unit? So on page 5 of your handouts, you'll see that we have a Making Assignments worksheet. We have all smiley faces on this, but we're thinking about an average census. Let's say we have 24 patients and we have 6 RNs here, okay, and 2 nursing assistants. So these folks, the blue are the RNs, and then we have our nursing assistants here. And this might be our charge RN, or it could be your unit secretary. Think about what you need the most. If you've got a lot of admission orders, maybe you want to use some of that salary for a unit clerk or secretary that could be cross-trained. Think that through on this particular shift. So here we have, we see direct lines where this is a group of patients, say this is a geographical assignment, and maybe we've got an RN here who's taking a group of patients alone without help from a nursing assistant. And these heavy patients that we have here, we have 2 RNs working with a nursing assistant with that group. And so really looking at maybe this RN is doing a lot more of the care because the nursing assistant can only manage this certain group of patients geographically, thinking about, who's going to be doing what tasks. So here we are. Think this through, and we ask that you just pause the webinar for a minute, and if you're in a group, talk through who could be doing what. If this happened to be our unit and there were 24 patients, and think it through. Think it through what tasks or processes, who should be doing what would the charge RN role look like? Would this be another RN, or do we pull this person out to be the charge RN? Thinking about how you can set up the care and the work that needs to be done. If you're not sure how much the nursing assistants can really get done on your particular unit, we just recommend you look at your star performers and see if they're doing all the work that's being assigned, how many patients can they take. Then contrast that with the care that's being done by some of the folks that are at your lower level of performance. And somewhere in the middle there then is what a reasonable nursing assistant assignment could be given an average, quote-unquote, group of patients. So think through all of that and talk that through. You might even take this worksheet to your unit council so that you can, play around with some ideas around who could be doing what. So thinking about the tasks or processes that each person would do, who's accountable for the total patient care, which is, of course, the RN that's assigned to that patient, and is that RN giving the initial direction and observation and feedback? How does that RN evaluate the data or information? Does that RN take that step back to reflect and look at the trajectory of care? Are they getting better? Are they getting worse? How stable is this patient? Are they going through the expected progress that you would want to see? Are they setting up debriefing? And what kind of norms can you set up to structure communication opportunities for people? So that actually brings us to another way of thinking about the progression of your shift. So we've got another worksheet there that you can use now or take to your unit council to think about when people would do what. So if you think about trays and vital signs and other things that you might have, like maybe you have a quiet time in the afternoon, we put together the times in half-hour increments, and so you can think about what is the function. Does the manager do it? Does the charge nurse do it, the RN, the nursing assistant, or someone else? How is rounding being set up? And thinking this through, and we did put on page 6 the bundle of 10 best practices, so you can look at that as a shared mental model that just to use as a recommendation for setting up checkpoints and timelines and really getting an idea about how you might put your breaks together so everybody actually gets to breaks and that people are assigned appropriately. And if you do put your handoffs together so that the RN and nursing assistant are going through, the oncoming nursing assistant is with the RN receiving report, and initial direction can be given then with at least one of the nursing assistants' group of patients. Then the off-going nursing assistants can be rounding, toileting, answering call lights, making sure that care is being done. And actually, people are finding that they get another half hour or more out of their shift because they've seen all their patients during that period of time, and they're actually being able to give initial direction to the nursing assistant and get the information that's necessary. Setting up some time within the patient so that you're clear about what the patient's priorities are. These are just some ideas of when you might take some time to look through the processes and what times they might occur and who would be doing those. Always making sure people get their breaks and meals, absolutely necessary. Just a quick assignments game. This is another way of thinking about making assignments. So in this case, we have 20 patients and 2 empty rooms. And we have an RN who's an experienced med-surg RN. We have RN2, a new grad. We have RN3 that's a float from OB because maybe they're from labor and delivery, but you're in a med-surg unit and this person had to float in. And then we have an experienced LPN. Now, if you don't work with LPNs, you can leave this person out of the equation. But for those of you who do work with LPNs, it's good for you to know what their state practice is, so you know what you can assign, and also looking at your job description in your unit or in your organization. And then we have patient care techs, and these are, we give you a lot of resources, a lot of staff to play around with on this game, but we have 1 to 3 of them, so there's 3, and they're experienced and they're from your floor. So what are some possibilities? Well, let's say we take your med-surg RN and make that person the charge RN. And that person could deploy a patient care tech, and then we could have the second RN, the new grad, with one of the experienced patient care techs with certainly some supervision and help and mentoring from the charge RN, and we could take that RN from OB and assign them a functional role so that they're working with an LPN from the floor and that PCT from the floor so that they can, maybe they're doing vital signs and helping with care and they're doing some of the work, but maybe the charge RN needs to do a little help with supervising of the LPN in making sure that the care is progressing the way it should with these groups of patients. Let's think about some other possibilities. You could have one of the RNs being the charge RN role, and then we could have a functional role. So an RN can do a functional role, med nurse, treatment nurse for a group of patients, or the PCT could do a functional role. They could do the rounding, continue to round on all the patients, or they could do all the vital signs, or they could do some different kind of a role. We could have an RN teamed with another RN so that they're working together with a group of patients. We could also have an RN float with the floor PCT to take care of, helping them get oriented. We could have the RN new grad with the PCT help. We could have an RN working alone, and we could have an RN working alone but have some of the tasks assigned to one of the PCTs. So there's many different ways that we could consider configuring the work that needs to be done. So if we think of how we would take one person out of there to be the charge RN, and then the PCTs could be supervised by different RNs, and remembering fewer were better. We could have an RN working with total patient care, and we can put together an RN and an RN together with other assistance by the charge RN. So there are many different ways that we can look at parsing out the human resources to get the work done appropriately for the right outcomes for this group of patients. So just think that through, and you could have an LPN doing functional work as well. Move on then to page 8. And if you'd like to take some time and pause and really work through some different scenarios with our assignment games and think that through, these are some resources for you to take back to your professional practice council or unit council. As we test our assignments, let's now go to page 8 and think about rating the assignments now. And the box to the left of the statement in the 0 to 1 is not at all, 2 is rarely, 3 is occasionally, 4 is yes most of the time, and 5 is all of the time, so that you can find out how well you're doing with your assignments as they stand. So we'll give you a few minutes to do that, and you can pause the webinar. What we want you to think about is whether or not your assignments reflect those clear lines of authority and reporting mechanisms, so that there's supervision of assistive personnel by RNs, and that's very clear, and also reasonable, that it's possible for those RNs to supervise the nursing assistants the way they're being deployed now. That your assignments take into account the actual patient clinical situations, acuity, stability, and safety. And we're hoping you're real high on that all of the time, a 5 for that. Thirdly, that your assignments match the right competent person to the right task. That fourthly, in our workplace, assistive personnel or technicians routinely report to no more than 2 RNs, and that's one that we want to hope for. Fifthly, that the assignments are set up so that nurses are able to offer initial direction and reconnect at checkpoints and debriefing effectively so that the teams can grow and improve. Sixth, that the change of shift processes, breaks, and meals are set up so that on-unit coverage is equal and meets the patient's needs during all periods of the 24-hour day. Seventh, that most of the time we are able to get our meals and breaks because we're supported in doing so by our assignments and the efforts made by the leaders or charge nurses, perhaps, and our fellow team members that want us to get off and get our breaks and meals. Eighth, that most of us on our team are highly satisfied with the assignments we receive, and we feel that they're fair to all of us. Our next step to leadership at the point of care include really thinking then, taking that testing of your assignments and looking at the critical thinking that you take to the next steps. What happens tomorrow when you go back to work? Think about the research about the care models and the teamwork and how that intrigued you. Were there some new ideas or models that you might want to look at? When you reflected on your unit or your shift, what roles do you think are overworked? Even when the star performer is doing this particular job, are they able to get out on time? Does the work get done? And then look at those star performers. What do they do differently? What can we learn from them? And which of the charge RNs or assignment makers seem to be able to do that well? They communicate the decisions. People don't argue with them. How do they do that? What can we learn from them? And how do they make those assignments stick but also make them well? And what what changes need to be made in the way we make assignments. So to what person or committee do you take this information or observation, and where do you want to take this thought process? If you're not already working with your unit counselor or managers or professional practice committees or quality committees, can you take these thoughts to a group to begin to look at how you might alter the way you're making your assignment so that the correct delegation and supervision is realized on a daily basis, and certainly that the best care is being provided? What is your commitment to your team and to your patients starting after this webinar is completed and you complete your test? If you have questions about your area and what you might want to do to help make things better for your assignment making, call us. We can give you some individual or organizational assistance and have a conference call or work with you individually. And so Florence Nightingale said this: let whoever is in charge keep this simple question in her head. Not how can I always do the right thing myself, but how can I provide for that right thing always to be done? Thank you for joining us. And remember to contact us if you do have questions or have any trouble with the Hanston Learning Center. Thank you for joining us today.